Hello guys. So now with the continued topic of abdomen, we'll be dealing about hepatology. Okay, here we'll be studying about hepatology. Then we'll also study about gallbladder pathologies and also the pancreas. Okay, so first we'll see about liver anatomy. Some of the important things about liver anatomy are, so let us see about the architecture. Okay, so in liver, it is going to be a hexagonal lobule. The hepatocytes will be arranged into. Okay, so surrounding will be the central lobe with portal triad on the edges. Okay, so basically it looks like something like this. Okay, so hexagonal shaped, and centrally this is the central vein that is there, and around in the edges there will be portal triad. Okay, so the portal triad will be in the edges. Okay, so this is how the hepatocyte architecture will be. Okay, so this is exactly how it will be there. Okay, now the portal triad I told you, right? So it contains of portal vein, hepatic artery and a bile duct. Okay, so all the hepatocyte architecture is divided into zones. Okay, zone 1, zone 2 and zone 3. Okay, so zone 1 is periportal zone. Okay, and zone 2 is the middle zone, and zone 3 is the pericentral zone. Okay, so it is going to be zone 1, zone 2 and zone 3. Okay, so this is how it is being divided into. So see, periportal zone is where the first of it will be first affected in viral hepatitis. Okay, so because hepatic artery is there, so it can carry all the viral hepatitis and cause the hepatitis here. Okay, so this is the area. Okay, then pericentral zone. So pericentral zone is the first zone that is prone to ischemia, because see, it is away from the hepatic artery, right? So it is too much away from the hepatic artery. If there is ischemia, this is what will be first affected. Okay, then it is also sensitive to toxins. Okay, so this is the thing with respect to zones of liver. Okay, coming to some of the important cells of the liver, the Kupffer cells, which is acting like a macrophage. Okay, in liver cell, so Kupffer cells will act like macrophages, and there is something known as Ito cells. Okay, hepatic stellate cells, which will be in the space of Disse. Okay, so basically if this is the hepatic architecture, so there will be something known as space of Disse. Okay, that is connecting the edges to the central vein. Okay, so here there is something known as the space of Disse, where the Ito cells will be there. So the major function of Ito cells is it stores the vitamin A and also produces the extracellular matrix. Okay, extracellular matrix production will be done by the Ito cells. I'll tell you the clinical significance of it when we move on. Okay, then coming to liver segments, so this is how the liver segments will be there. Okay, so please remember the falciform ligament. Okay, falciform ligament, and it is the Cantis line that divides the liver into right lobe and left lobe. Okay, so it is also called as costocaval line. Okay, then coming to this is very very important, hepatobiliary triangle versus Callett's triangle. Okay, so hepatobiliary triangle, the borders is basically the common hepatic duct, the cystic duct, and the base of the liver is what forms the hepatobiliary triangle, whereas the Callot triangle, same on the lateral and the medial side, but the base will be formed by the cystic artery. Okay, so here it is the cystic artery that forms the Callot triangle border. Okay, so the reason why it is important is during surgeries, either it might be laparoscopic or open cholecystectomy. So this area is what we focus on to know the location of the cystic artery. Okay, so that we wouldn't damage it. Okay, so this is the clinical significance of it. Then coming to liver function tests, some of the basics are, so basically liver function test, what we do is we are taking the liver enzymes that the liver produces and also the hormones that the liver produces to know how the liver is functioning. Okay, we'll be taking the bilirubin levels, the transaminase levels, ALP, GGT and other functional hormones that the liver produces. Okay, so bilirubin normal level will be 0.2 to 1.2. Direct if there are two kinds of bilirubin, that is direct bilirubin and indirect. Here direct means conjugated bilirubin, whereas indirect means unconjugated bilirubin. So direct will be raised in obstructive type of jaundice, whereas if it is hemolysis, it is going to be indirect type of jaundice. Okay, if both are raised, it is going to be hepatocellular carcinoma. Okay, so please remember this. Then coming to transaminase, we all know, right? ALT, AST and all these things. Okay, see, if it is the ALT is specific to liver. Remember L as L, liver, for liver. ALT is very specific to liver. If ALT is more than AST, then it is going to be viral hepatitis or non-alcoholic fatty liver disease. Okay, whereas if AST is raised, then it is going to be acute fatty liver disease. Basically, ALT and AST is nothing but these are all the enzymes that are present in the cells of the liver. Okay, what happens is when these cells get damaged because of these etiologies, so all these enzymes will start leaking out of the cell and it will be raised in the blood. So this is the thing, that's it. Okay, then please remember, if it is more than 1000, if the AST value is more than 1000, it is going to be acute viral hepatitis. Okay, then coming to ALP and GGT, remember I had told ALP is what tells the function of osteoblasts in orthopedics. We had discussed, right? The first line of orthopedics was ALP is what tells us the activity of osteoblasts. So basically ALP plus GGT, if it is raised, it is going to be cholestasis. Okay, so ALP plus GGT, if we are gonna if it is raised, it's going to be cholestasis. If it is only the ALP that is raised, it is going to be bone function. That I told you, right? Osteoblastic activities, what it tells. Okay, coming to GGT, in chronic alcoholics, GGT will be raised, and also we discussed it, cholestasis, and in also some drug toxicity and all, GGT will be raised. The other functions that we see with respect to liver is, so basically the production of albumin and clotting factors. Okay, so if we'll see whether albumin is low and clotting factors are low with respect to the functioning of liver. Okay, then moving on to liver disorders. Okay, we learned about the basics of anatomy, we learned a little bit of physiology based on how the hormones are. So now let us see the liver disorders. Okay, so liver diseases can be divided as, basically can be also called as fatty liver. Okay, so liver disease can be divided into non-alcoholic and alcoholic liver disease. Okay, so in non-alcoholic fatty liver disease, so it can be divided as without inflammation and with inflammation. Without inflammation means, so it is basically metabolic syndrome associated. Okay, like obesity and all these things will lead to without inflammation. Okay, it leads to cellular ballooning and necrosis will happen because of increased oxidative stress. Okay, then coming to with inflammation means it is the steatohepatosis. So basically the fatty liver thing. Okay, so which will lead to, again here also the same thing, but with inflammation will be there. So what happens is oxidative stress will be happening and it will lead to cirrhosis and hepatocellular carcinoma. Okay, so how do we manage it? So basically vitamin E has been proven to reduce the oxidative stress, right? We had discussed in biochemistry also. So vitamin E is very important. So the main management will be, so basically managing the underlying disorder. So that is metabolic disorder can be managed by weight loss. Okay, and also improving the insulin sensitivity. Okay, so this is how we can manage non-alcoholic fatty liver disease. Okay, coming to alcoholic fatty liver disease, so there are stages with respect to fatty liver disease. Okay, so these stages are nothing but the pathogenesis, the way the pathogenesis pathway happens with respect to alcohol. So let us see how it happens. Okay, so alcohol, what it tells is, we had seen the glycolysis process and all, right, in biochemistry. So let us go back to the revision of it. Okay, what alcohol tells is, so it increases the NADH in the body. Okay, so it increases the NADH and tells that there is enough energy. Okay, so basically glucose was there and glucose was trying to generate ATP. But what happens if we consume alcohol? Alcohol gives rise to NADH. Okay, so this NADH tells that there is no need of ATP, there is enough ATP. Okay, so when the body has enough ATP, what happens to the glycolysis process? I told you, right, in biochemistry, it is gonna go to fatty acid synthesis, because enough energy is there. So that is why it will go take another route of fatty acid synthesis. Okay, so now too much fatty acid synthesis is happening. Okay, so what happens? So all this fatty acid synthesized will be storing in liver, we discussed, right? So all this fatty acids that is being synthesized will be storing in the liver. So this is known as steatosis. This is the first stage of alcoholic fatty liver disease. What happens is, so all this the fat starts storing in. So the Kupffer cells, I told you, right, these are the macrophages of the liver. So this gets activated and inflammation cascade will start. Okay, so all the inflammation cytokines and all this will start releasing, okay, interleukins and all. This leads to Mallory-Denke bodies. Okay, Mallory-Denke bodies, which is very pathognomic of steatosis stage. Okay, please remember this. Okay, so when this inflammation is happening, after certain days it will lead to hepatitis. Okay, so this is the second stage of alcoholic liver disease. Okay, then what happens after hepatitis? The Ito cells, I told you, right, the stellate cells, the supportive cells of hepatocytes. So these cells gets activated. Okay, so these were the matrix producing cells. So what happens? So there is increased amount of collagen deposition that is happening. Okay, so when this is happening, it will lead to fibrosis, sclerosis and all these things. After fibrosis and sclerosis, what will happen? Portal hypertension, right? So all the portal veins will get clumped by this fibrosis and all. So that is why there is increased pressure in the portal vein, which leads to portal hypertension. Okay, so this is the main pathogenesis of portal hypertension also. Okay, so then after this happens, it will lead to cirrhosis. Okay, so this is the third and final stage. Okay, so after cirrhosis, if the cirrhosis is not resolvable, it leads to liver failure. Okay, so this is how the entire process of pathogenesis of alcohol induced fatty liver disease will happen. Okay, so the same thing with respect to non-alcoholic fatty liver also. If there is obesity and if there is a non-alcoholic fatty liver also, the same thing, same pathogenesis is what it follows. Okay, so basically from the stage 1, that is there also it was steatosis, here also steatosis is there. Okay, so basically if fatty acid is high, which will lead to oxidative stress and lead to all this cascade of reaction and leads to finally cirrhosis and failure. Okay, so alcohol consumption and obesity is nothing different, no different. Okay, so both are same. Okay, then coming to assessment of severity, we'll do something known as Madry score. Okay, where more than 32 means severe. Okay, so while doing Madry score, if more than 32 value is there, it is going to be severe case of alcoholic fatty liver disease. Okay, coming to management, what we are going to do, basically we are removing the trigger, that is cessation of alcohol. Okay, then coming to symptomatic management. Okay, we'll do some symptomatic managements. There is a new FDA approved drug. Okay, so there is a new FDA approved drug, please be aware of this. So this is called as resmetirom. Okay, so resmetirom, which is given 800 international units per day. What it does is, so it basically reduces the fatty acid synthesis and reduces the beta oxidation. Okay, it increases the beta oxidation. So that is lowered fat storage inside the liver, which will improve the steatosis and fibrosis. Okay, so please remember, this is a newly approved drug. Okay, so resmetirom. Okay, then coming to the other pathologies of liver. So let us see about the infections that might happen in liver. Okay, so other than hepatitis, let us see all the other infections that happens. Then we'll go on to hepatitis. Okay, so there is something called as amoebic liver abscess. Okay, which will be by Entamoeba histolytica. Okay, so Entamoeba histolytica, the protozoan, will cause amoebic liver abscess, which so it will be increased in cases of liver. Okay, so alcoholic patients are at a increased risk of entamoeba histolytica. The features will be basically fever and right upper quadrant pain. Basically it is an abscess, right? So right upper quadrant pain will be there. Then dysentery, okay, because of entamoeba histolytica. So basically it also causes flask shaped ulcers. We had discussed in microbiology, right? So flask shaped ulcers in the gastrointestinal tract. So that is why dysentery will be there. Okay, so then coming to LFT will be normal. Okay, LFT will be normal, but there will be amoebic antibodies that are there. Okay, so amoebic antibodies along with the abscess. Okay, when I take an imaging of the liver, so there will be abscess on any one of the lobe. Okay, what do we do? So we basically aspirate. Okay, so we'll basically aspirate, and the aspirated fluid will be anchovy pus. Okay, please remember this, anchovy pus. Okay, so then the definitive management to treat the protozoan is metronidazole. Okay, then coming back to pyogenic liver abscess, it is basically caused by E. coli or Klebsiella. Okay, so basically the bacteria. So increased risk in type 2 diabetes or diabetes or sepsis. Then the features will be same like abscess on liver abscess only, fever, right upper quadrant pain, and also septicemia. Okay, then liver function test will be abnormal. Okay, it will be variant, and blood culture will be positive. So coming to imaging, there will be multiple irregular septations will be there. Okay, so if we take the aspiration of that particular region, so it will be yellow green pus that will be there. Okay, so how do we treat? So basically broad spectrum antibiotics. Okay, then coming to hydatid cyst, you know that, right? Echinococcus granulosus. Okay, so how will so this is so we are accidental hosts basically. So what happens is it will be high in sheep and dogs. So by dog feces and all, so it might spread in veterinary guys and cattle handlers and all. Okay, so the clinical features will be there is no pain and no fever, just like amoebic liver abscess or pyogenic liver abscess, there will be no pain or no fever. Okay, so the main thing will be anaphylaxis based on the hypersensitivity reaction that these echinococcus granulosus will be forming. So there will be anaphylaxis. Okay, so here also the LFT will be normal. Okay, but if we do the imaging, there are many stages. Okay, that staging is known as Gabri classification. Okay, Gabri classification. So which will look like honeycomb, water lily. Okay, so this is how the imaging will look like. Okay, if we do the investigations, so there will be hydrated serology. Okay, that is IgG will be positive. This is a chronic infection, so that is why IgG will be positive. Okay, and the aspiration will be a clear fluid. Okay, then how do we manage it is by giving albendazole and kill the parasites, and then we'll do something known as pair. Okay, pair approach. So this is how we deal with all the three types of infections. So now we'll move on to the specific, that is hepatitis infection. Okay, so hepatitis is very important for our entrance exams. So there are five main types of hepatitis, that is hepatitis A, B, hepatitis A, B, C, D, and E. Okay, so hepatitis A is basically fecal-oral route, and also hepatitis E is also fecal-oral route. Okay, whereas hepatitis B and D will be parenteral route, and hepatitis C is blood-borne. Okay, so by needle prick and all, so most probably it will be blood-borne infection. Okay, then please remember hepatitis A, please try to match hepatitis A and E together. Okay, so both are almost similar. Okay, it is also acute and acute case of hepatitis, whereas it is self-limiting. Okay, hepatitis A is very self-limiting and also asymptomatic. Okay, whereas hepatitis E is fulminant in pregnants. Okay, please remember it is dangerous in pregnants. Okay, so here there is no carrier. Okay, hepatitis A there is no carrier, and management will be supportive. Okay, supportive type of management is there. There is a vaccine for it. It is called Havrix. Okay, coming to hepatitis B and D, it is same. Okay, so hepatitis B and D is nothing but same. So basically hepatitis D, what happens is it is a it is a co-case with hepatitis B. That's it. Please remember in that way. So basically, it is going to spread by parenteral route. That is what I told you, right? So then coming to it is basically chronic case. Then the symptoms will be fever, rash, and it might lead to carcinoma, hepatocellular carcinoma. Okay, so there will be carriers, and the management will be basically antivirals, alpha interferons. Okay, there is a vaccine for hepatitis B, that is hepatitis B vaccine, right? So we give it in the national immunization schedule. Okay, so this is by IgG, okay, immunoglobulins, that we can treat them. Then coming to extrahepatic symptoms, there will be aplastic anemia. We will come back to extrahepatitis features when I'll discuss about hepatitis C. Okay, so here in hepatitis C, the features will be very bad. Okay, so it is a very bad prognosis also. So cirrhosis will be there and carcinoma will be there. So here also in hepatitis C there are carriers. How do we manage? Is antivirals, alpha interferons. There has been no vaccine developed for hepatitis C. Okay. So now the extrahepatic features with respect to hepatitis B and C is, so here in hepatitis B there will be aplastic anemia, membranous glomerulonephritis, and polyarteritis nodosa. Whereas in extrahepatic for hepatitis C is, there is a B cell, NHL, and MPGN will be there, membranoproliferative glomerulonephritis. Then vasculitis, just like here hepatitis B, here it was PAN, but here there will be other vasculitis. Then coming to porphyria cutanea tarda will be there. Then lichen planus. Okay, please remember this, all extra hepatic system, extrahepatic symptoms, and which virus infection is causing it. Okay, so please remember that. Okay, then coming to the serology of hepatitis is what has been the examiner's favorite. Okay, examiner's favorite, this has been the previous year topic. Okay, so what happens is, so how do we test for HAV is basically, so let us see what are the things that are there. So basically HAV, okay, so if it is hepatitis A that I want to see, it is going to be anti-HAV, it will be raised, and anti-HAV IgG, anti-HAV IgM, and anti-HAV IgG. So I told you, right, IgM means always acute, whereas IgG is chronic. So that is the thing. Okay, if it is a chronic infection of hepatitis A that is going on, it is going to be IgM A that will be raised. Okay. Then coming to hepatitis B is what is very important. See, I'll tell you the basics. Okay, so basically there is antigens and antibodies with respect to viruses. In any viral infections, so there will be antigens of the virus, and there will be antibodies that are generated by our body to fight the virus. Okay, so antigens also can be tested, whereas antibodies also can be tested. Okay. So antigens within the hepatitis B virus is HBsAg. Okay, so Australian antigen. So this will be on the surface of the virus. Okay, hepatitis B CAG will be the core. Okay, C for core. Okay, so this will be the core of the virus, whereas HBE meaning small e. Okay, so meaning it will be produced during the replication. Okay, virus will produce this during the replication. Okay, so I'll come back to you why it is important. Okay, so now the antibodies that are generated in our body to these antigen, against these antigens, so there will be anti-HBs, anti-HBC, and anti-HBE. Okay, so these are the antigens and antibodies that are produced in the body. So now let us see, based on this these basics, so how the different kind of clinical features will be. Okay, so if there is an active infection that is going on with respect to hepatitis B, there will be HBsAg that will be positive, and if there is a vaccinated case, then it is going to be anti-HBs that will be positive. Okay. Then coming to core antigen. So core antigen cannot be tested. Okay, so please remember, core antigen cannot be tested. It is the antibody. So that is with respect to the core antigen that can be tested. Okay. So what it tells is, so if it is a core antigen IgM antibody that is generated, it is going to be acute case. Okay, whereas if it is a core antibody IgG, then it is going to be chronic case of hepatitis. So here also in HbA, we discussed the same thing, right? So in the same way, so here also IgM means acute case, whereas IgG means it is chronic case. Please remember it is the C, okay, the core antigen that we are seeing. With respect to HBeAg, I told you, right? So basically it tells the replication that is going on. So if there is high amount of HBeAg, the antigen, so that means that there is active replication that is going on, okay, meaning it is transmissible, okay. So the person is spreading the disease. It means that the person is spreading the disease, okay. So if it is the anti-HBe, it is gonna tell that there is low transmission, meaning the transmission has already stopped, okay. So one of the extra edge point with respect to anti-HBC is that, see, there is something called as window period where no other serological markers will be raised except for anti-HBC, okay. So anti-HBC will be raised in the window period, okay. So this is an extra edge point. So this is all and everything you need to know with respect to the serology of hepatitis. So if you know this basics, you will be able to solve any type of question, okay. So based on this only, we will be deciding whether they'll ask you. So they'll give you one serology marker question, and then they'll ask you whether is the person vaccinated, or is an active infection, or a carrier, or a low transmittability, or high transmissible case, and all these things, okay. So that is the thing with respect to hepatitis is done. So now we'll go on to liver cirrhosis, and then we'll go on to the complications of liver cirrhosis, okay. So liver cirrhosis, we discussed, right? Because of some insult, there is increased fibrosis and sclerosis, which will lead to portal hypertension and cirrhosis, okay. So it is basically chronic irreversible, okay. So irreversible scarring of liver tissue. So basically etiopathogenesis, we discussed all the etiologies: alcohol, virus, metabolic disorders, autoimmune disorders, non-alcoholic disorders, drugs, toxins, or biliary obstruction. All this will cause repeated injury to the hepatocytes, which will lead to the fibrosis, okay, which will cause regenerative nodules and impair the vascular tissue, okay, including the portal triad, okay. So portal vasculature is also affected, which will finally lead to failure, okay. So this is the staging how the pathogenesis of liver cirrhosis happens, okay. Then coming to how the patient might present with, so it is basically almost failure like symptoms only. So the early stages will be with ascites, jaundice, encephalopathy, variceal bleed will be there, then HRS, then hepatorenal syndrome, and coagulopathy, okay. So these are the things that the patient might present with, okay. So when we do the LFT, we discussed, right, in the beginning itself, LFT will be deranged, okay. AST, ALT will be raised because all the hepatocytes are damaged. Whatever is inside is coming out, okay, leaking out. So when we do ultrasound, there will be nodularity, okay. So the liver would look something like this. It used to be smooth, right? It was supposed to be smooth like this, but there will be nodularity, okay. So how do we diagnose is based on child's pug score and MELD score. So the meaning is, so this is telling about the severity, okay. So how we should manage the patient, okay. So the child pug score is basically telling us to the severity, is telling us the severity, and MELD score tells us the whether the patient needs a transplant or not, okay. So whether the transplant is needed or not, and where exactly to put in the transplant list is what will tell, what the MELD score will tell, okay. So please know the difference between these things. Then coming to management, so nothing can be done for cirrhosis, as I told you. It is irreversible. All the other things that are causing can be avoided, so to avoid the failure, okay. So symptomatic treatment can be given, and all the underlying causes can be treated, and the basic mainstay of treatment is transplant, basically, okay. Then coming to complications, I told you, right? So it might be portal hypertension, hepatocellular carcinoma, variceal bleed, ascites, and hepatorenal syndrome, and encephalopathy can be the complications, okay. So portal hypertension means if the pressure is more in the portal vein, if the pressure is more than 10 mmHg, it is going to be portal hypertension, okay. For variceal bleed, what we do is we'll give Minnesota tube. Okay, so this is the thing. So now let us discuss about variceal bleed. Okay, so with respect to the management of variceal bleed, so first thing is, if some bleeding is happening, the first we have to do is resuscitation. So basically we'll stabilize the patient, then we'll give terlipressin, then the our drug of choice will be octreotide. Okay, then we'll do variceal bleeding, we'll do the we'll do endoscopy, and we'll do variceal bleeding wherever is required. So if this is also not working, we'll go for shunting. Okay, so this is how we manage the variceal bleed. Okay, so please remember, I told you, right, in biochemistry also, in urea cycle we are supposed to remove the ammonia, so to avoid hyperammonemia. If hyperammonemia is there, it will lead to hepatic encephalopathy. So that is why in hepatic encephalopathy, I told you that if there is increased bleeding in the gastrointestinal tract, it will lead to increased amount of ammonia production. Okay, so this thing we have to address first before doing anything. So that is why we will be controlling the bleeding first to avoid hyperammonemia, and to reduce the worsening of hepatic encephalopathy. So that is why we'll treat the bleeding first before doing any other thing. Okay, so now coming to another complication, that is hepatorenal syndrome. So basically what happens is, portal hypertension is there. So what happens is, there is splanchnic vasodilation in the gastrointestinal tract. What happens is, near the gastrointestinal tract, all the this is called splanchnic vasocirculation. Okay, so these things will get dilated because of portal hypertension. Okay, to compensate. So this compensatory effect is bad for us. What happens is, there is effective circulatory volume lowering. Okay, so there will be volume, so the volume that is being circulated in the systems will be low. So what happens, our kidney will detect this volume lowering, and tells that, oh, the system has to go vasoconstriction. Okay, so the renin activation will be there. So that is why the this system will go under vasoconstriction to compensate the loss of volume. Okay, so that is happening because of the vasodilation. Okay, so this systemic vasoconstriction also constricts the renal vessels also, right? So this chronic renal vasoconstriction will lead to reduced GFR, and eventually will lead to renal failure. Okay, so this is known as hepatorenal syndrome. Okay, because of the hepatic portal hypertension, it is leading to renal failure. This is what hepatorenal syndrome means. Okay, so this is the thing. Okay, now coming to management. So here also we are giving terlipressin. The reason why we are giving terlipressin is to reduce the to increase the splanchnic vasoconstriction, so that there will be no loss of volume into the peritoneum, and there will be a normal amount of volume in the systemic circulation, so that there won't be a RAS pathway activation. Okay, and also we'll be giving norepinephrine. Okay, so norepinephrine to deal the vasodilation that is happened. Okay, so this is the thing with respect to hepatorenal syndrome. So now the other complications are the Budd-Chiari syndrome. Okay, so what happens in Budd-Chiari syndrome is, so please see that, so it is a non-cirrhotic congestion of the vasculature. What happens is, so there is a outflow obstruction that is happening. So this is the liver, and this is the outflow that is happening from the liver. The portal vein carries the blood towards the liver, and the hepatic vein carries it out from the liver. Okay, towards the heart. Okay, but what happens if there is some obstruction in the the hepatic vein? What happens is, there is increased congestion, right? So because there is increased congestion in the portal triad, okay, portal vein, there is increased congestion, which might eventually lead to cirrhosis. Okay, so this is a non-cirrhotic liver disease. Okay, so Budd-Chiari syndrome is this one. This is how the pathogenesis occurs. Okay, what are the clinical features? Is basically hepatomegaly and nutmeg liver. Okay, so it looks like a nutmeg. Okay, so this was a previous year question. Okay, nutmeg liver can be seen where? Okay, so see a nutmeg liver image, and This was an image based question that they asked. Okay, so this is where we'll get to see hepatomegaly, because all the blood is pooling inside the liver only. Okay, because it is not going to the hepatic vein and to the heart. Okay, so this is what happens with respect to Budd-Chiari syndrome. Okay, coming to portal vein thrombosis. So this was in the hepatic vein that is happening, the obstruction. But if there is a obstruction in the uh, portal vein itself, somewhere here outside the liver, so it is going to cause portal vein thrombosis. Okay, so it is a non-cirrhotic. This is also a non-cirrhotic type of portal hypertension. Okay, so again, so portal hypertension is there because there is a blockage, but it is not because of the liver that is happening. So it is from outside the liver the issue is. Okay, and also please be aware of some of the other insults of the liver other than alcohol and all these toxins is basically Wilson's disease and hemochromatosis. Wilson's is copper deposition, whereas hemochromatosis is iron deposition. We discussed it, hepcidin is affected, so that is why iron is getting stored, because all this will be in the liver only. Liver is the main pathology, so that is why we'll be doing liver biopsy. Okay, so in these cases liver biopsy is only what is the diagnostic or investigation of choices. So please be aware of these two things. So now coming to the main complication, that is ascites. Okay, so ascites, please remember these fluid volumes, and this has been asked. Okay, so puddle sign, so basically if the volume in the volume of ascites is just 120 ml, how can we elicit is by puddle sign. So we'll make the patient go on all four limbs, and we'll try to elicit if there is fluid. Okay, so all the fluid will be in the stomach. Okay, so if this is the all four limbs, this is the legs and this is the hand, so we'll go tell the patient to be on all four limbs, and so all four limbs. So here we can elicit the fluid volume. So if it is 120 ml, so if it is about 500 ml, how we can elicit is by shifting dullness. We'll try to tap the abdomen. So if this is the abdomen, we'll try to tap on all sides, and see, we used to see in our final year, right? So this is the shifting dullness that we do. And fluid thrill is, we'll tap on one side and we'll try to elicit the vibrations on the other side of the abdomen. So if it is 1 to 1.5 liters, it is going to be elicitable. Okay, so fluid thrill. Okay, if it is more than 2 liters, it is going to be called as tense ascites. Okay, so these are the terms with respect to ascites. Okay, so if it is more than 25 mmHg of pressure, then it is also be called as tense ascites. Okay, then sag ratio is what tells us whether it is exudative ascites or transudative. Remember, in pleural effusion also we discussed the same thing, right? So please remember, here it is the gradient that we are taking. Basically sag ratio is nothing but serum albumin versus serum ascites albumin gradient. Okay, so what we'll do is, we'll check the serum albumin minus the acetic albumin ratio. Okay, so if there is serum albumin high, then it is going to be not an infective, meaning so all the albumin will be inside the blood vessel only. So that is why the serum albumin will be high. Whereas if we take the acetic albumin, if acetic albumin is high, means that there is some protein leakage that is happening in the vessels. Okay, so that is why the ascites is happening. So that means that the vasodilation is because of some inflammation that is happening. Okay, so that is why, so if it is if the ratio or if the gradient is more than or equal to 1, it is going to be the portal hypertension. Okay, it is the portal hypertension that is causing the leakage of fluid. Okay, so it is basically a transudative fluid that is been inside the ascites. Okay, but if it is less than 1, it means that the ascitic of albumin is high, means that there is leakage of albumin inside the peritoneum. Okay, that is happening. So that is why it is the infective cause that can be detected if it is less than 1. Okay, so please remember this sag ratio and the clinical significance of this sag ratio. Okay, and please note that, so suppose if the ratio is more than 1.1, okay, more than or equal to 1.1, but if it is less than 2.5, it means that it is cirrhosis. The reason why it is less than 2.5 is it cannot rise more than 2.5. Okay, so the reason why it is less than 2.5 is because there is no albumin production at all, right? In the case of cirrhosis, there is no albumin production at all. So that is why it might lead to it might lead to lowered albumin, but not very less than 1.1 gradient. Okay, so that is the thing with respect to cirrhosis. Okay, this is the question they'll ask you, not any of this 1.1 and all these things. They'll ask you definitely this cirrhosis thing only. Okay, so that is the thing with respect to ascites. Okay, so what are the complications of ascites is, we know that, right? SBP, that is spontaneous bacterial peritonitis. So the most common organism is E. coli that can cause it, and also TB can cause peritonitis, where there will be lymphocytes that will be raised. Okay, then the clinical features will be abdominal pain, tenderness will be there, then coming to chills, fever and all will be there, tachycardia will be there, all the prodromal symptoms basically will be here. Okay, so these are the clinical features. How do we diagnose is basically if it is more than 250 cells per unit liter, so it is called as SBP. Okay, so neutrophil level more than 250 cells per unit liter, per microliter, it is going to be SBP. Okay, so we'll be doing the culture. Okay, so culture will be positive, and we'll diagnose it as SBP. Okay, so what do we do? Basically, abdominal paracentesis is what we do. We'll send the sample. We'll do both. Based on the amount of fluid that is present, we'll do abdominal paracentesis, both diagnostic and therapeutic paracentesis. Okay, so what is the other management is basically IV cefotaxime is what we give. So then ceftriaxone, basically third generation cephalosporins is what we give. So please note that omeprazole has been found to be increasing the risk of SBP. Suppose a patient comes to you with cirrhosis and all, so and he's probably having ascites, we wouldn't know. For heartburn and all, so we would be prescribing omeprazole. Okay, so please note, in these patients, please do not try to prescribe omeprazole, please give pantoprazole. Okay, so omeprazole has been found to be causing a highest risk of SBP here. Okay, so it might be a complication. So now to the last point of hepatology, that is liver failure. Okay, so in liver failure, there are stages. Okay, so compensated liver failure and decompensated liver failure. In compensated liver failure, there will be no varices and with varices. Okay, so this is how we'll tell whether it is compensated or not. Okay, so with no varices will be there, or with varices will be there. Decompensated meaning it is acute cause of liver failure. What happens is there will be increased ascites and also variceal bleed will be there. Okay, so there it was only the varices that we are trying to decide from, but here it is going to be complicated case, so that is why ascites will be there and variceal bleed will be there. Okay, so this is decompensated case of liver failure. Okay, most common cause of liver failure in India is viral hepatitis. Okay, so it is not alcohol, it is the viral hepatitis that is causing it. The clinical features, just like cirrhosis that we discussed, right? So remember this man, and you will be able to identify it. Encephalopathy, fatigue will be there, jaundice, yellowish discoloration, gynecomastia will be there. Then palmar erythema, spider angioma is very pathognomic for liver failure. Then edema will be there. Okay, dark pale stool will be there because of the jaundice. Then ascites definitely. Then the liver will be nodular on ultrasound. Okay, so I told you, right? So basically cirrhosis is there. That is why it looks like a nodule. Okay. Then we'll decide as hyperacute liver failure and acute liver failure based on the encephalopathy that is happening. Okay, if the encephalopathy is happening within 1 week, okay, within 1 week of the liver failure, it is called as hyperacute liver failure. Whereas if the encephalopathy is happening after more than 4 weeks, it is going to be acute type of liver failure. Okay, so please remember this. Then I told you, right, Child-Pugh score and MELD score is basically what is telling the severity and the transplant need. Okay, so this is how the survivability and the transplant need will be decided by the Child-Pugh score and MELD score. So, okay, this is all and everything you need to know with respect to hepatology. Okay, so now we'll move on to gallbladder pathologies. Okay, so in gallbladder pathologies, so this is how we can classify the gallbladder pathologies into. So with respect to inflammatory gallbladder pathologies, it will be the cholecystitis and cholangitis. Okay, cholecystitis is with respect to infection of the gallbladder, whereas cholangitis is the infection of the ducts, okay, so the gallbladder ducts, okay. Coming to cancer, it is going to be the cholangiocarcinoma. Stones will be, if it is gallbladder, it is cholestasis, okay. Then if it is the duct that is affecting, then it is going to be choledocholithiasis, okay. Then coming to structural abnormalities, it is going to be biliary stricture and primary sclerosing cholangitis. So let us see one by one, okay. So before going into gallbladder pathologies, so main thing we want to know is non-obstructive and obstructive jaundice, okay. What is the difference and how it happens? So see, basically in non-obstructive jaundice, it is going to be hemolysis that is high, okay. So that is why the unconjugated bilirubin is being increased, okay. So unconjugated bilirubin level is increased, so it will go and there is increased amount of liver conjugation that is happening, okay. So that is why there is increased level of bilirubin, okay. So what happens is this bilirubin reaches the intestine, and here in intestine, so the gut bacteria will convert the bilirubin into urobilinogen, okay. Please remember, there is increased urobilinogen. Normally urobilinogen will be there, but because of increased hemolysis, there is increased urobilinogen, okay. So this urobilinogen, what happens is, some of them will be going with the stool as cercobilin, okay. So with the stool, the cercobilin will be gone, but as the amount is too much, so there will be too much blood reabsorption, okay. So this blood reabsorption will cause urine to be yellow, okay. So all this urobilinogen that is being reabsorbed into the blood will cause the urine to be yellow, okay. So that is the thing with respect to non-obstructive jaundice. Whereas in obstructive jaundice, so there is a block in the duct, right? So conjugation and all is normal, okay? But there is a block in the duct. So what happens is, this conjugated bilirubin cannot reach the intestine, right? Because there is a block in the cystic duct or the choledochal duct, okay? But what happens is, as the bilirubin is not reaching the intestine, so what happens is, there is pale and clay colored stool, okay. So there is no urobilinogen. So urobilinogen was supposed to form the cercobilin and give the stool the color brown, okay. But here there is no urobilinogen reaching the gut. So what happens is, the stool will be pale colored and clay like, okay. And some of them will back up to the blood, okay. So all the conjugated bilirubin will start backing up into the cystic artery and so basically portal veins and all. So here it will reach the systemic circulation and go to the kidney, okay. In kidney, it starts getting filtered out. What happens here, it is the conjugated bilirubin that is getting filtered out, so in high amount. So that is why there will be bilirubinuria, okay. Bilirubinuria will be there. So that is why the urine would look like cola colored or dark urine, okay. Cola colored urine will be there. So this is the difference between just by looking at the stool and urine itself, we can judge it whether it is the obstructive or the non-obstructive jaundice we are dealing with. This is what they'll give in the cases, okay. So with respect to cases, they'll tell you the stool color and the urine color. So just by that, oh, okay, so this is where the pathology must lie in, is how we can differential diagnose, okay. So coming to hereditary hyperbilirubinemia. So this is very, very important. This is the previous year topic, okay. So this is very, very important, okay. So what happens is, there are two kinds of hereditary hyperbilirubinemia, okay. One is the failure to conjugate the unconjugated bilirubinemia, and other one is the failure to transport the conjugated bilirubin, okay. So it is almost like unconjugated and conjugated bilirubinemia, but here the enzymes are defect, okay. So it is basically like jaundice only, but here the enzymes are defect in the liver is what is happening, okay. So the deficiency with respect to unconjugated to conjugated is basically the UDP glucuronidase transferase is what is affected, okay. So please remember, this enzyme, okay, is what is being affected. There are two kinds of disease with respect to this failure to conjugate the unconjugated bilirubinemia, that is Gilbert's disease and Crigler-Najjar disease, okay. So Gilbert disease is a mild form, okay. Mild loss of enzyme is there, so that is why mild jaundice is there, and it is a benign disease. Whereas the Gilbert is, there is absent enzyme, okay, enzyme is not there at all, so that is why it is a severe case, and here jaundice might happen, and the basically the unconjugated bilirubin is high, right? So no, this is a non-obstructive type of jaundice. So where the jaundice will be unconjugated bilirubin will be high, and there will be kernicterus. Kernicterus meaning the brain is also getting involved. Okay, so the mainstay of treatment will be transplant. Okay, because there is no enzyme. What is the use of liver then? So that is why we are gonna go for transplant. Now coming to failure of transport. Okay, so there will be the conjugated bilirubin should be transported. Okay, so conjugated bilirubin should be transported. If the transport protein is absent, if the transport protein is affected, so then it leads to Dubin-Johnson and rotor hyperbilirubinemia. So the thing is with the Dubin-Johnson is there is defective liver excretion. So basically there is no transport that is happening. All the conjugated bilirubin that is being formed will be staying in the liver itself. So that is why there is a defect in transport and will lead to black liver. Okay, so all the conjugated liver conjugated bilirubin is in the liver only. So that is why black liver is formed, and this is a benign condition. Okay, whereas in rotor this is a mild condition of Dubin-Johnson. So similar to Dubin-Johnson only, but no black liver will be there. Okay, so no blackening of the liver will be there. So that is rotor. Okay, please be aware of Crigler-Najjar and Dubin-Johnson. This is what you have to differentiate based on the enzyme is present, or based on how the patient presents with. Okay, so this is how we decide the hereditary bilirubinemia. Okay, then coming to biliary atresia. The first thing we'll discuss biliary atresia, because the thing is the way it presents. Okay, so there is a fibro obliteration and destruction of the ducts. Okay, which will lead to cholestasis. Okay, so there is fibro obliteration, destruction of the ducts, so which will lead to cholestasis. Okay, there is no obstruction that is causing because of stone or something. It is the structural abnormality that is causing the obstruction. Okay, so this is okay, associated with absent or abnormal gallbladder on ultrasound. Okay, so there might be absent or abnormal gallbladder which can be seen on USG. How will the patient presents with? So patient will present basically with the pathological jaundice. Okay, so it is the kids that are always affected. It will be congenital thing that we can see, and kids will be affected with pathological jaundice for more than 2 weeks. So basically we were discussing jaundice with respect to pediatrics, right? So in neonatology there will be physiological jaundice and pathological jaundice. So the physiological jaundice, breast milk is what we discussed, but pathological jaundice, so this is the thing. Okay, so this is how it might happen. There might be biliary atresia that we should be going and investigating. Okay, so the patient will be presenting with jaundice more than 2 weeks. Then dark urine will be there, and then acholic stool will be there, and hepatomegaly on examination. Okay, so the most common reason for pediatric liver transplant is this thing only. Okay, so biliary atresia is where the most common reason for pediatric liver transplant. Okay, we can't do anything, we'll have to go for liver transplant. Okay, so investigation is basically USG, HIDA scan, and liver biopsy is what we do. Okay, then we'll also do the intra-op cholangiography and see where the atresia is exactly. Okay, there are different kinds of atresia. Please go through all the images or all the types of biliary atresia. Okay, they might ask you what is the management that we do is Kasai procedure. Okay, so we'll do something known as Kasai procedure. Okay, this is after if within less than 60 days, if we are gonna do an intervention, this is gonna be the Kasai procedure that we do, or else we are gonna go for, I told you, right, liver transplant, the most common reason. Okay, then coming to stones is very important, right, with respect to gallbladder stones and the duct stones. Okay, if it is the stones that is being formed in the gallbladder, it is going to be cholelithiasis. Okay, so basically there are two kinds of stones, that is the cholesterol stones and the pigment stones. Cholesterol stones are radiolucent, whereas the pigment stones are radio opaque. Okay, so please remember this. Okay, then coming to clinical features, basically we all know, right? So if it is a gallbladder stone, biliary colic will be there, nausea, vomiting, and a dull basically right upper quadrant pain will be there. Okay, so we all know to elicit Murphy's sign, right? So Murphy's sign, just like McBurney's sign in appendicitis, it is going to be the Murphy's sign that we elicit in gallbladder stones. So investigation, basically USG and CT will be doing. In CT there is something known as Mercedes-Benz sign. It is gonna look like something like this. Okay, so Mercedes-Benz sign and the seagull sign. Okay, seagull's sign will be there. Okay, then coming to MRCP is investigation of choice. We are gonna see meniscus sign. Okay, so meniscus sign will be seen in MRCP. So management will be ERCP, sphincterotomy can be done. So we can open up the sphincter and allow the gallbladder stones to be passed out, or we can place a stent. Okay, if it is a chronic case of cholestasis, we can place a stent again and again. If it is causing, we can place a stent and allow the stones to pass out. And there is something called as Burheen's technique. Okay, what we do is after after all the after all the stones have been passed out, the missed stones will be removed by this Burheen's technique. Okay, please remember this. This is an extra edge point. Burheen's technique is what we use for missed stone removal. Okay, then coming to choledocholithiasis. See, there is something called as primary and secondary choledocholithiasis. So basically it is the duct. Okay, so gallbladder we discussed. Okay, gallbladder, if the stone is there, it was cholelithiasis, whereas if it is a duct is having the stone, it is going to be choledocholithiasis. Okay, so it is going to be two types. One is primary and the secondary. Okay, so primary meaning the stone has formed in the duct. Okay, so primary, basically CBD stone is formed in the bile duct, whereas if the stone has migrated from the gallbladder, it is going to be called as secondary. Okay, so secondary is known as from the gallbladder. Okay, then the most common ones are in primary it is going to be brown stone, whereas in secondary it is going to be the cholesterol stone, that is most common. Okay, so I want you guys to know one of the very important topics with respect to gallbladder stones is, so with regards to retained stones and recurrent stones. Okay, retained stones are nothing but if we after cholecystectomy, okay, if the stone is there, if we get to see if the patient comes again with pain and all, and if we do the ultrasound, and if we get to see the stones again, if it is less than 2 years of cholecystectomy, then it is going to be called as retained stone. Okay, so probably we have missed during surgery is what is called as retained stone. Okay, so if it comes, it is gonna present to you within 2 years. Okay, so that is what is retained stone. Whereas recurrent stone is if it is after 2 years, that means that the stone has formed again. Okay, so it is not the retained stone, we haven't missed anything, so it is the it is coming again, so that is recurrent stone. Okay, so surgery that we do is de novo stone formation. Okay, so this is what we do. Okay, this is the surgical so basically we'll do surgery, sorry. Okay, so we'll do surgery. Surgical removal is what we do. See, this is basically recurrent, meaning this is a de novo stone formation. De novo meaning so freshly formed stones is there with respect to recurrent stone. Okay, so that is all and everything you need to know with respect to stones of gallbladder. Okay, so now going to biliary stricture, it is also nothing but it is just like biliary atresia only, but it is in the adults that happens. Okay, so what happens is this is a complication of dislodged stone. Okay, so dislodged stone from the gallbladder or the bile duct. What happens is it will go and reach the ampulla of water. Okay, so ampulla of water is where the common duct opening of pancreatic duct and the bile duct, right? So here is the ampulla of water. Okay, so ampulla of water, the large area. So here what happens is there will be the stone will get dislodged and might come and form here. Okay, this will form the fibrosis around the stone. Okay, so this is known as stricture that is formed, that is biliary stricture. Okay, so it leads to cholangitis and the pancreatitis, because ampulla of water was the common opening for both pancreatic duct and the biliary duct, but both are compromised, so that is why there might be cholestasis and pancreatitis that might happen. Okay, this is the complication of biliary structure. Okay, then coming to the inflammatory disorders that I told you, right? Cholecystitis we have to discuss. So cholecystitis, so it is basically inflammation of the gallbladder. Okay, so clinical features will be divided based on the whether the calculus status is there or acalculus, meaning due to impaction of the stone is what the cholecystasis is happening, or because of some other infection is what the cholecystasis is happening. Okay, then Murphy's sign here also basically we'll be eliciting the pain. Okay, then gallstone ileus. What happens is this is a complication where the gallbladder stone will be dislodged and will be going to the GI tract. So this will go and create a fistula in the GI tract. Okay, so what happens is all this stone will get dislodged and will go and form a fistula in the GI tract. Okay, the main thing is it will obstruct in the ileocecal valve. Okay, so this is known as a Rigler's triad. The clinical feature is Rigler's triad, where there will be pneumobilia. So the SI obstruction will be there, and gallstone can be seen in that particular area. Okay, so this is gallstone ileus. Okay, the complication of cholestasis is if it is a chronic case, there will be porcelain gallbladder, basically the calcified gallbladder. Okay, so the gallbladder gets calcified. Okay, so that is why in gallbladder pathology, the Carboyer's sign, right? Carboyer's law tells that gallbladder won't be palpable. The reason why it won't be palpable is because of this shrinking, because of the all this cholestasis and all that has happened. Okay. Then coming to biliary tract disease, acute cholangitis. Okay, so acute cholangitis is inflammation of the biliary tree that is happening. So two things. Okay, it can present with two things, that is Charcot's triad and Raynaud's pentad. Okay, so biliary tract disease with acute cholangitis can present with these two things. Okay, what does that mean? So Charcot triad is nothing but jaundice, fever with right upper quadrant pain. Okay, so with right upper quadrant pain it is there, then it is going to be Charcot's triad. So Raynaud's pentad is nothing but this Charcot's triad plus there is altered mental status and shock that is there. Okay, so this is how the acute cholangitis will present with. So cholecystitis is the gallbladder inflammation we saw. Okay, whereas this cholangitis is basically the duct inflammation that we are discussing about. The duct has been inflamed. Okay, so this is the presentation that it's gonna come with. Okay, then other one is the other type of inflammation with respect to duct is primary sclerosing cholangitis. Okay, so this is basically associated with ulcerative colitis. It is an extra intestinal symptom. So what happens is there is onion skin bile duct fibrosis. Okay, onion skin like fibrosis will be there in the bile duct. Okay, so this is the thing. So please go see an image of this. Then on ERCP, if I take a look, it will be looking like a bead shaped, which is very pathognomic with respect to ERCP. So please remember this in primary sclerosing cholangitis. Okay, there is something known as primary biliary cholangitis, which is autoimmune. Okay, so this is the thing with respect to all the inflammations and infections with respect to gallbladder. Okay, so now coming to the cancer of gallbladder, it is cholangiocarcinoma. Okay, it is a very aggressive tumor which will arise from the bile duct. Okay, from the bile duct epithelium is what this arises from. There are types. Okay, intrahepatic, perihilar and distal type. Okay, so the risk factors are all the things that we discussed till now might go and form the risk. Okay, the most important thing is please remember the liver fluke and the schistosomia. We learned about the schistosomia, that trematodes, right? So this might cause this carcinoma of gallbladder. Okay, and also a liver fluke, that is opistho Ricus. Okay, opisthorhynchus can be a risk factor of cholangiocarcinoma. Okay, please remember this. Okay, then the clinical features how the cholangiocarcinoma will present with is the painless, jaundice will be there, then weight loss will be there, pruritus, and the dark urine or pale stool will be there because of the obstruction that is causing because of the gallbladder cancer. Okay, so I was telling you about the Carboyer's law, right? So basically it tells that painless, palpable and enlarged gallbladder plus if there is a jaundice, it is unlikely that is a gallstone, because I told you, right, gallstone, what happens is basically pain will be there, Murphy's sign and all will be there. Okay, so if it is an enlarged gallbladder, it is unlikely that it is a gallstone. Please remember that, and your Curvaizer's law will be very easier for you. Okay, so reason why is because of the inflammation and all this gallbladder tissue will get sclerosed and will start becoming thinned out. Okay, thinned out. Okay, whereas if there is an obstruction, okay, if there is an obstruction outside the gallbladder, what happens is there is increased stasis that is happening, and the gallbladder will start enlarging. Okay, so that is why if it is a cancer, okay, somewhere cancer is here meaning, so this will get enlarged, right? So that is the meaning of Curvaizer's law. Okay, then coming to diagnosis, so basically LFT will be deranged and the tumor markers are CA 19-9 and CA. Okay, then CA. Okay, then the investigation of choice being USG, MRCP and CT MRI is what we do. Okay, then we'll take a biopsy and we'll do the diagnosis. How do we do the management is basically surgical approach. First we'll do the cholecystectomy, or we'll go for Whipple's surgery. Okay, then after that we'll do chemotherapy and palliative stenting can be done to remove any gallstones that are there, or if there is any other pathologies. Okay, so the surgical methods are cholecystectomy and Whipple's surgery if it is a distal gallbladder duct that is involved, being involved here. Okay, also if it is the higher stages, hepatectomy can be done. Okay, perihilar or the intra, in case of perihilar and intrahepatic cholangiocarcinoma. Okay, so I told you, right, there is intrahepatic and the perihilar tumors that might be there with respect to cholangiocarcinoma. Okay, this is all and everything you need to know with respect to gallbladder. Okay, so now the last topic, that is pancreatic disorders. Okay, so let us discuss about that. So in pancreatic disorders, the main thing is acute pancreatitis and chronic pancreatitis is what we'll have to differentiate. Okay, so acute pancreatitis basically happens because of autodigestion of the pancreas by the enzymes. Why it happens is basically some gallstone. I told you, right? So there might be gallstone that has been dislodged and that is going and blocking the ampulla of water, and that is how the pancreas might be affected, and also the gallbladder is affected. So this is one of the cause for acute pancreatitis. Then the mumps can lead to pancreatitis. Then autoimmune diseases, trauma can lead to that, and hypertriglyceridemia in dyslipidemias, and then ERCP and drugs. So all these causes will cause the acute pancreatitis. Then the diagnosis is basically acute epigastric pain will be there. This is how the patient will present with, which will be radiating to the back. So that is why, so this acute epigastric pain with that is radiating to back can also be differentially diagnosed as the peptic ulcer or a duodenal ulcer, and also we should not rule out we should have actually rule out the aortic dissection or something like that, aortic dissection or abdominal aneurysm that might have happened. So that is why acute epigastric pain with that is radiating to back should go for ultrasound, and then that should be diagnosed. Okay, before doing that we'll also be sending all the blood values, right? So here there will be serum amylase to lipase that will be raised more than 3 times the normal value. Okay, then coming to imaging will be positive with respect to pancreatitis will be looking inflamed. Okay, then coming to clinical features that the patient might present with, there is called something called as Mohammed prayer sign. Okay, so Mohammed prayer sign meaning so there will be, when we when we try to do the namaste sign, so there will be the gap that will be between the two fingers. Okay, so between the fingers there will be gap between them. Okay, there is something called as Cullen sign and Gray-Turner sign. You know that, right? Cullen sign is para-umbilical. Okay, so para-umbilical graying or bluish discoloration will be there, whereas Gray-Turner sign will be near the waists. Okay, so the bluish discoloration will be near the waists. Okay, then there is also something known as Fox sign. Okay, which is painful sign. Okay, this is the pancreatitis clinical features. Okay, how will the pancreatitis complicate into is basically pancreatic pseudocyst. Okay, please go and see an CT image or X-ray image of this. So they might ask you the image based question for pancreatic pseudocyst. Okay, then there might be abscess, necrosis and organ failure that might happen. How do we manage? Is basically we divide it into mild, moderate and severe acute pancreatitis. We'll give the fluids, that is RL is ringer lactate is the fluid of choice. We'll give opioids because it is a severe pain that is happening, so that is why we'll go for opioids, tramadol and all we'll be giving. Tramadol is the analgesic of choice that we give for acute pancreatitis. Then there is no antibiotic to be given because it is not the bacterial infection that is causing the pancreatitis, and there is no NPO. Okay, so there will be no NPO. Okay, then the specific management will be done. Okay, for that particular disease that is happening with if it is the gallstone, then we will remove the gallstone. So that is how we manage. The specific management is removing the causative. Okay, this is acute pancreatitis. Coming to chronic pancreatitis, it is basically because of the chronic inflammation of the pancreas or atrophic calcification of the pancreas. Okay, then basically the causes are alcoholics, and because of genetics is the cause. Basically most probably alcoholics only, right? So in any alcoholic might come to you with epigastric pain, think of pancreatitis. Okay, so diagnosis will be basically pancreatic insufficiency. All the hormones and all that is secreted by the pancreas will be reduced and the enzymes will not be elevated. So in acute pancreatitis we saw it, right? Serum amylase lipase was rising more than 3 times the normal value, but here the enzymes will be not elevated. Okay, pancreatic pseudocyst, I told you, right? Go see an image of it. Image based question might be asked. So it will be most common in the lesser sac. Okay, so in the lesser sac of the stomach, the most common pancreatic pseudocyst might be formed. What do we do? How do we do the management? Is cystogastrotomy. Okay, cystogastrotomy is what we do for the management of pseudocyst. Okay, coming to CA pancreas, the last topic, that is there are many types of CA cancer. The most aggressive is adenocarcinoma. Okay, so adenocarcinoma is the most aggressive form. Okay, in neuroendocrine tumors there are 2 types, insulinoma and gastrinoma. Okay, so insulinoma, so basically there will be Whipple's triad. Okay, what is Whipple's triad? So basically there will be low RBS, meaning there will be low hypoglycemia, and also relieves by glucose. Okay, this is the Whipple's triad. So basically there is a issue with glucose. Okay, so low random blood sugar will be there. So because of that low hypoglycemia, and when we give glucose, the symptoms will relieve. So this is with respect to insulinoma. Okay, because there is too much insulin is causing too much surge of glucose into the muscles and other tissues. So there is no glucose at all in the blood. Okay, so that is what is happening. Okay, coming to gastrinoma, so please remember Zellweger syndrome. Okay, Zellweger syndrome. Okay, this is so the syndrome will be recurrent peptic ulcer, abdominal pain will be there, diarrhea, and GERD will be there. We remember, right? So like in GERD, I had told you this GERD might be a complication of gastrinoma. Okay, then please remember the Passaro's triangle just near the stomach only. So this is where the most common site of gastrinoma will be there. Okay, Passaro's triangle. Okay, then coming to investigation, so it is the endoscopic ultrasound that we do and diagnose. The staging also can be done for this pancreatic cancers. The surgery will be Whipple's surgery. Okay, so Whipple's surgery, it is nothing but pancreatico-duodenectomy, meaning, so if it is the duodenum and if it is the head of the pancreas that is there and this is the tail, we are going to do, and we are going to remove the duodenum and this pancreatic head. Okay, so this is the thing that we do with respect to pancreatico-duodenectomy. Okay, so this is Whipple's surgery, very very famous surgery. Okay, so this is all and everything you need to know with respect to pancreatic disorders, and we are done with the entire hepatology. Okay, so now we are done with hepatology, meaning we are done with the abdomen chapters. Now we'll be going on to pelvis chapters. That is we'll be dealing with the nephrology, and then we'll go on to obstetrics and gynecology with respect to pelvis. Okay, thank you.